Hi, guys, and welcome to the lecture over the skeletal system. So, this is going to be quite a long one. We are talking all parts of the skeleton. So, definitely have your PowerPoint open so that you can pause and continue as you go, because this is going to be quite a long lecture. So, first of all, we're going to talk about how the questions are going to look like on the practical. Sometimes the quiz questions can look like this as well. But basically, you're going to be asked to either name the bone, name the part of the bone, like if I have an arrow pointing to it, or a label, for example, on the skull, specifically between the eyebrows, and I ask you to name that part of the bone. I would expect you to say that that's the glabella. I can also ask something about, name the neighbors, like what bone is proximal to this bone, or what bone is distal to this. So know the bones and where they are located in relation to each other, so that, if you do see a question like that, it doesn't trip you up. If I marked the acetabulum, that's how you pronounce that, acetabulum. It's the ball socket part of the pelvis, essentially, and asked you what bone would attach there, you would have to answer the femur. So make sure that you're reading the question so you don't accidentally assume I'm asking you to name the bone if I'm actually asking you to name something different or something related to that bone. Table 8.2 over here as well. These are just very common markings of bones. We've got some articulations here, joint surfaces, extensions and projections, depressions and passages and cavities. Just familiarize yourself with these terms so that when you do see something, like if you see process, you already know that that's some kind of protrusion, some kind of extension, some kind of projection, so that it doesn't, it's kind of a shortcut. If you know what these things are, it's kind of a shortcut into naming it, even if you may not have memorized this. If you know that that's a spinous process or something, you've got one leg up over just memorizing everything. So read through this table, be familiar with these words, because you are going to be seeing them throughout this lecture. Okay. The skeleton, 206 bones. Okay. So we have the axial skeleton, and we have the appendicular skeleton. The axial skeleton has 80 bones. The appendicular has 126 bones. So total bones in the body, there are 206. So the axial skeleton is comprised of 3 parts. It is the skull, the vertebral column, and the thoracic cage. So what it functions in, it essentially forms the central axis that supports the head and the neck, protects the brain, spinal cord, and thoracic organs. And that's everything highlighted in this blue-green color. So the skull is truthfully going to be the most difficult bony structure to learn. The one that's going to be a little bit difficult as well is going to be the pelvis, but it's not going to be anywhere near as difficult as the skull. There are 22 total bones in the skull, including cranial and facial bones. That also includes sutures. So what are sutures? You think of a suture, think about how you would use it in vernacular. So when we were talking skull, a suture is an immovable joint between the bones of the skull. So they look like little zigzag areas where the bones of the skull have fused, right? So we have coronal. So coronal suture sits across the top side. It sits across the top of the skull, side to side, like a headband, which we will look at. The sagittal suture, it's front to back along the midline on top of the skull. So it slices the skull left and right. Think sagittal plane, slicing in half left to right. Squamous is on the sides, so think squished on the sides of the head above the ears. And then we have lambdoidal on the back of the skull. It's an upside down V or Greek letter lambda. So that's the Greek letter right there, and that's what the lambdoidal suture looks like. Our cranial bones, we have two parietal, they're on top of the head. We've got two temporal, above the ears, one on each side. Occipital, that's the back of the head, that attaches to the neck. Frontal is the forehead. Sphenoid and ethmoid are smaller. They are tucked between facial, temporal, and parietal. And we'll look at those as well. So here are our skull sutures. So coronal, right there like a headband. Sagittal separates the midline, left and right. We've got squamous right above the ears, and then lambdoidal, upside down V shape or lambda symbol. Parietal bones, right there. Temporal bone, one on each side. Occipital bone, back of the head. Frontal bone, forehead. All right, so this sphenoid bone is the one that sits inside like this. Talk more on it as well. This is just so you kind of have a relation on where it goes. And then the ethmoid bone right there, part of the skull. Very porous. So anyways, we're going to talk about this. Very spongy. I shouldn't say porous. Very spongy. Okay. Skull bones. All right, so the frontal bone, what I want you to know to label is the glabella, which is the flat part between the eyebrows. So flat area between the orbits. And then it also houses the frontal sinuses, which are lateral to the glabella, which are beneath the eyebrows. So frontal bone, glabella, frontal sinuses. Parietal bones are bound by 4 of the largest sutures. So coronal, sagittal, lambdoidal, squamosal. And the parietal bone is going to be the only bone that's surrounded by all 4 sutures. Well, I shouldn't say bone, I should say bones, because there are 2. So parietal bones are the only ones that are going to be surrounded by all 4 of the sutures. Occipital bone, so back of the head, that includes the hole in the bottom of the head, so foramen magnum. So that's where the spinal cord comes out of. And the EOP, the external occipital protuberance. So protuberance is the part that sticks out, and the EOP is the knot in the back of the head. So if you feel right back there to the head and you feel the knot, that is the EOP, the external occipital protuberance. So you do need to know that. Temporal, so those bones are going to be on the sides of the head. They house the external acoustic meatus. So it's not meatus, it is meatus. So those are our ear holes. Sphenoid or sphenoid, however you want to say it, that is the keystone of the cranium. So remember, keystone of the cranium. All of the other bones, whatever is outside or inside, touch it somewhere. So all the other bones articulate with it. It keeps everything essentially locked into place. On the inside is the sella turcica, which we will look at, and it's a fossa for the pituitary gland. So it's the structure that holds the pituitary gland. It's cup-shaped or U-shaped. The sella turcica, it can be enlarged if there was a tumor on the pituitary gland. So we will look at what that looks like as well. Well, we can go back up a couple. So that's right here. Right? That's where the pituitary gland sits, and we'll look at it again as well. Okay. The sella turcica and the sphenoid. And then ethmoid bones, so that comes out of the front of the skull. Within the ethmoid is the cribriform plate, so that is the perforated bone for olfactory nerve. So what's olfaction? Olfaction is smelling. Okay, so in the ethmoid, we have the cribriform plate. It sits in the roof of the nose, the top of the nose, and it's perforated. So it's got a lot of those, perforations, holes for olfactory nerves to go through. It's covered in epithelial tissue that rests different nerve endings, so that if you have anything that you're smelling, if it's good, if it's bad, those olfactory nerves take that information straight to the brain, which tells you, oh, that smells good or that smells bad, and it kind of pinpoints what that smell is, right? Ethmoid sinuses are air pockets behind the orbits. The orbits are the eye sockets, and if you've ever had a headache behind the eyes, behind the cheekbones, close to the nose, you've probably had a sinus infection. So what gets inflamed there are the ethmoid sinuses. Okay. All right, so facial bones. Here's the sella turcica in this image. I know we looked at the cadaver skull, but here it is in this diagram. So that little U-shape, little cup shape, that is the sella turcica. But anyways, facial bones. So we have the mandible and the maxilla. The mandible is going to be the largest and strongest bone of the face. Just for future reference, if you ever hear me say something like, that's the largest, that's the strongest, definitely remember that, because that'll probably show up somewhere in the future, maybe on an exam, maybe on a practical, maybe on a quiz. So definitely note that. Also, whenever I say keystone or one of its kind, blah, 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 definitely put a little star there, because it will probably show back up, right? So anyways, the mandible, that's the largest, strongest bone of the face. That is the lower jaw, okay? So mandible's the lower jaw, and there is a small hole called a mandibular foramina or foramen. Anytime you see foramen, that's a hole. Mandibular foramina is a hole in the mandible. And that is the hole where dentists aim to inject different anesthetic, because there is a facial nerve that runs below it. And that's the nerve that they are trying to numb, so that if they are removing any teeth or, giving you a filling, anything like that, they can numb that nerve so that you don't feel the pain associated with that. So they are not making a new hole. They are injecting anesthetic into the hole that already exists in the face, called the mandibular foramina. Then we have the maxilla. So maxilla is actually made up of two bones that fuse in the front. Basically, where your front two teeth are, right there in the center, is where those bones fuse, and that makes up your upper jaw. So the maxilla is the keystone of facial bones. So all bones except the mandible articulate with the maxilla. So remember that. Zygomatic bones are the front half of the cheekbones, so nose to halfway to the ear. And then the zygomatic process is going to be the back half. So that's halfway to the ear we just left, all the way to the ear. So the back half of the zygomatic bone. And that whole framework of zygomatic bone and zygomatic process makes up the zygomatic arch, which we'll talk about as well. Okay, so nasal bone, that's the part that you put whenever you put your glasses on, that's the part your glasses sit on. Okay, so nasal bones are the bridge of the nose only. Lacrimal bone contains a fossa or passageway hole for tear ducts. So that runs from the corner of the eye down to the nose, and that's why your nose gets runny when you cry. Palatine bone makes up the roof of the mouth, but only the hard palate. So, the palate is made up of the hard palate on the front and the soft palate in the back. But the palatine bone is hard palate only, roof of the mouth. The vomer is the nasal septum. So, fun fact about this guy, avid drug users who snort, for example, cocaine, they don't have all of their nasal septum. So the drugs are actually deteriorating the epithelial tissue and bone so that it ends up actually rotting away, which is really not great. And those people have random nosebleeds, etc., etc. But anyway, so vomer is the nasal septum. We'll look at pictures of that as well. And then we have the inferior nasal concha. So 2 small bumps off the nasal septum that swirl the air around, allows you to breathe in. And touch the roof of your nose. So if there are any chemicals, your olfactory nerves will pick them up, right? So it's important. This inferior nasal concha are super important because they allow all air to travel through moist areas, which allows that air to moisten before going into our lungs. So on really dry, freezing cold days, or if you're in a really dry desert environment, something has to happen to moisten that air before it reaches your lungs so that it doesn't damage your lungs, right? So inferior nasal concha, they swirl the air in the nares and do that. Help assist in that. The hyoid bone is the only bone that does not articulate with any other bone. That bone helps move the tongue around. And then we have orbits. So orbits house and cushion the eyes. We have the nasal cavity that does that moistening of the air that we just talked about. And then we have the paranasal sinuses. Frontal, sphenoid, ethmoid, and 2 maxillary. They actually lighten the skull and they give sound resistance. So what that means, that can actually change the sound of your voice. So paranasal sinuses. Remember that. Lighten the skull, give sound resonance, ability to change the sound of your voice. All right, so ethmoid bone. So here's that cribriform plate we were talking about. It's right there. Sella turcica of the sphenoid. So here it is specifically. There's another superior view of cranial cavity, but the mid-sagittal view is the best one for the sella turcica. Here's the maxilla. So these 2 bones fuse right here. Palatine bones. Here's an inferior view. Zygomatic bone, again, that's the front half of the cheekbone. Zygomatic process, temporal process of zygomatic bone. And then together, we call that the zygomatic arch. Lacrimal bones. Remember, lacrimal bones contain the fossa for tear ducts. So right there where the eyes are, right there, sit right behind the nose. That's why when you cry, your nose gets runny too. There's the fossa. There's the lacrimal bone. Nasal bones, where our glasses sit. Inferior nasal concha. So those are the two small bumps off the nasal septum. The vomer. So the nasal septum. Here's the anterior view, mid-sagittal view. It's all the way back. And we have the external acoustic meatus. So external openings for our ear holes. Right there. Mandible, lower jaw. Mandibular notch is right there. Mental foramen is right there. Hyoid bone. Remember, this one doesn't articulate with any other bone. Helps us move our tongue. And we are moving on. Okay, so vertebral column. There are 26 bones in the vertebral column. We have curves that evenly deflect weight. We have 3 regions of the vertebral column that we study. So we studied the cervical region, that's the neck, thoracic region, that's the upper back, and then the lumbar region, which is the lower back. We also studied the sacrum and the coccyx. Okay, so we have 7 cervical neck vertebrae. We have 12 thoracic middle back vertebrae. And I think I said upper back earlier. Middle back, yeah, thoracic, middle back. I guess if we go to upper back, we're in the neck area. So cervical, thoracic, lumbar, sacral, coccyx. And here it is broken up. So anyways, 7 cervical neck vertebrae, 12 thoracic middle back vertebrae, and then 5 lumbar lower back vertebrae. We have 5 sacral bones. They are fused together. And then we typically have 3 coccygeal bones. That's the coccyx region, coccygeal. But 3 bones of the coccyx, they're also fused together. So if you were asked to run this, you would say 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 3 coccyx. So 7, 12, 5, 5, 3. I said that a few times. You should probably write it down, okay? Because you are going to be asked this. Top down, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, 3 coccygeal, coccyx region. All right, and then we have curves too. So we have a lordotic curve. So that's a forward arch. In pregnancy, women develop lordosis of the lower back where it curves forward. That's a good way to remember that. And then we have thoracic sacrum, kyphotic curve. So arch backwards. Kyphosis happens in utero. So think of a fetus. It just curves inward on itself, right? So lordosis, arch forward, kyphotic, arch backward. And here are some examples of different abnormal spinal curvatures. So scoliosis is a lateral curve in the spine, shown in picture A. Hyperkyphosis is hunchback. So you can see how that spine is arching backward. And then hyperlordosis is a sway back where the vertebrae spinal curvature arches forward. So in pregnancy, this is temporary, typically goes away after childbirth. And again, remember, newborns have kyphosis all the way down. So think about how they hang out in utero. It's just kyphosis, 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 kyphosis. Okay, and that's it. Moving on. All right, ligaments of the spine. So ligaments of the spine help with shape. They help prevent overbending. It gives you limitations so that you basically don't hyperextend or do something to easily hurt yourself. So we have a few different ligaments here, and this is hard to find a good picture of, so we're just gonna talk it through. So we have an anterior longitudinal ligament. It is anterior to the vertebral body. Okay, so it's going to be the front of the vertebral column outside of the spinal cord. So right here, this green is the anterior longitudinal ligament. So right here. So these are cervical vertebrae, C1 through C7. We also have a posterior longitudinal ligament, PLL. It is posterior to the vertebral body. It is weak, so this is going to be inside canal, essentially. Posterior to the body. Okay? And then we have what's called a ligamentum flavum, anterior to the posterior element. So it comes down the inside of the spinous process. So here's the spinous process. So that's this stuff that's sticking out. That's the spinous process. The ligamentum flavum is right here. So it's anterior to the posterior elements. It comes down the inside of the spinous process. So what does all of this mean? Let me ask you this. What sits in the hole in the middle? The spinal cord, right? So the anterior longitudinal ligament is the only ligament that does not impact the spinal cord. The rest of them do. So the ligamentum flavum, for example, that one can compress the spine if it gets thickened, right? So what can cause it to thicken? Age, inflammation, injury, anything like that. So, but those are the only three I want you to know and be able to label if asked. I probably won't ask you to label these on the practical, but you will have to answer questions on the quiz about, which ligament is anterior to the vertebral body, which is posterior to the vertebral body or weak, which is anterior to the posterior elements. So know the difference there. So ALL, PLL, and then the ligamentum flavum. Okay, intervertebral discs. We have the annulus fibrosus, which is an outside fibrous ring, and we have a nucleus pulposus, which is a thick jello center, okay? So that's what that looks like. Nucleus pulposus in the middle, gelatinous, annulus fibrosus on the outside. You can remember that? Think annular rings. Think annular rings on a tree. Those tree rings, that's what they're called, annular rings. So annulus fibrosus are these annular rings on the outside. And then the nucleus pulposus is on the inside. So the annulus is super strong, fibrocartilage woven outside. It holds in this nuclear gelatinous center, right? If something were to happen to the annulus where the nucleus pulposus was able to leak out, like in this picture, herniation of nucleus pulposus, you would be in a lot of pain. This would be like putting acid on your spinal nerves. If this gel ever touches the nerve, that would be excruciating pain. Some problems that can arise here are disc herniations or prolapsed disc or bulging disc. Okay, so all three of these are correct. All three of these are talking about the same thing. It is not a slipped disc. This disc has not slipped. What's happened is that the annulus, this fibrocartilage woven outside, something has happened to it, whereas partially or completely ruptured, and this nuclear gelatinous center is seeping out and into the spinal nerves. So lots of pain here. Something else that can happen is called a sequestered disc. So this is when the nucleus pulposus has leaked completely out and is floating around in the cerebrospinal fluid. Everywhere it touches, it sticks to like sticky glue, and it has to be physically scraped off the spinal cord with surgery. There's no other solution. Everywhere it touches causes essentially chemical burns to those nerve structures, and surgeons need to go in and completely scrape that out. So that's super fun for the people who have to go through that. And now we're going to talk about parts of the vertebrae. So a few diagrams here. The vertebral body is the large anterior part. So the vertebral body is this part. The posterior arch is the entire back half. So the spinous process right here, that's what sticks out. That's what you can touch. That's the posterior part. So this is the entire back half. The pedicle right here, this little indentation, pedicle, that is the bridge that connects the vertebral body to the posterior arch. So pedicle separates it essentially to where, if I were to ask you to label it, you know that the pedicle underneath, well, I guess anterior to the pedicle is the vertebral body, posterior to the pedicle is the spinous process. So that's that. The vertebral foramen right here, the center, that is the hole in the middle of the vertebrae. We also call it the vertebral canal, and that's where the spinal cord descends. The intervertebral foramen, let me see if I have a nice picture anywhere here. So right here, this little opening, that is a hole in the side between pedicles where the nerves come out. Okay, so that is formed by the SAP, superior articular process, the IAP is the inferior articular process, and the body, the vertebral body. So spinal nerves exit there. The SAP is at the top junction between the lamina and pedicle. So the lamina is this part right here, this little flat part, and the pedicle is right there. The SAP sits between that, and it's very hard to show a picture without having this in a 3D model, essentially. And then the IAP is at the lamina pedicle junction, but on the inferior side. So right below it, which is not pictured here. This right here, but you can't really tell. So superior articular process, and then inferior is going to be opposite it. There's another vertebra that comes in and attaches and forms a joint, and that's called the facet. So smooth ends of SAP and IAP. The facet is the joint. Okay, let's see. Transverse process. So those come off of the sides of a vertebra, and those are our wings, what you would associate as wings. And then the spinous process, like I said, is the part that you can feel on your back. So that sticks out the back. Posterior lamina is a flattened area right there between the spinous and transverse process. Something about the lamina that's really interesting. Sometimes we have something called laminectomies. So that happens where a surgeon will cut out one side of the lamina, not both, just one side of the lamina, to give space for a herniated disc so that there's less pressure and less pain and more area for that herniated disc to pooch out of. But that's it. So spinous process at the back, lamina are the flat sides. Facet is actually where the joints are. Pedicle separates the vertebral body from the posterior arch. Vertebral foramen is the hole in the center. Transverse process are the wings. The superior articular process, the inferior articular process, are very difficult to point out here. We'll see those in class. But the hole that's formed there between the SAP, IAP, and the body that allows spinal nerves to exit is called the intervertebral foramen. So definitely know that. I think that's it for this slide. Okay, so cervical vertebrae. So we have 7 cervical vertebrae, and each is labeled as C1, C2, C3, C4, C5, C6, C7. So the letter tells you what region we're looking at, C, cervical, and then the number tells you which exact vertebra we're looking at. C3 through C7 are typical vertebrae, so they have an oval body, they have a short spinal process, most are bifid, so that means instead of one tip sticking out the back, they have 2, so each one has 2 tips sticking out the back, except C7. C7 is the only one that has one big spinous process. So it has what's called a vertebra prominens. So it's a long, non-bifid spinal process. So C7 is there so that your head doesn't go too far backwards when you're rolling your head backwards. And that's this one that's sticking all the way out down here. That's C7. So this one is the only non-bifid spinal process. Make sure you know that. The rest of them, C1 through C6, are bifid. Again, they have oval bodies. The vertebral foramen, so that hole in the middle, is large and triangular. And there are intervertebral discs between all of the cervical vertebrae. All right, so C1 and C2 are a little bit more special. They actually have their own names. C1 we call the atlas. It is ring shaped. Think about how in mythology, the world of mythology, Atlas held up the big round world. Well, C1, the atlas, holds up our big round head. It doesn't have a body. It doesn't have a spinal process. It is a ring with 2 lateral masses. C2, the axis, so the dens on the body. It's got short spinal process and a short transverse process. So the axis, the C2, it has a dens sticking up on the body that sticks straight out of the top of the vertebra. So the dens, anytime you see dens, think dental, think tooth. Some folks thought it to be tooth-shaped, and that's where it's got its name. So it has a short transverse process, short spinous process, and it is mostly body with dens. I think I made a mistake earlier when I said C1 through 6 over here. C3 through C6 are bifid, but C7 is the only one that's not. C1 and C2 are in their own field there. So apologies for that mistake. I just realized I made it. C3 through C6, non-bifid spinal processes. I'm sorry. C3 through C6 are bifid spinal processes. So each one has 2 tips sticking out the back. C3, C4, C5, C6 is each bifid. So 2 tips sticking out the back. And then C7 is the one that's long and non-bifid spinal process. And that's the one down here with just 1 sticking out the back, okay? C1 is the atlas. It does not have a body or a spinal process. And then C2, the axis, it has a short spinal process and a short transverse process. So note that. Apologies for my word vomit earlier. Okay, so this is what that looks like. Cervical vertebral bodies right here. Spinous processes back here. C1 atlas. So it's ring shaped, holds up the head. C2 axis, so there's that tooth-like projection right there, C2. Then we have the cervical spine. And you can see how much longer C7 is than everything else. Okay. So moving on to thoracic vertebrae. So this is T1 through T12. T1 looks more cervical. T12 looks more lumbar. T2 through T11 look very thoracic. So basically, as we go from T1 through T12, we're gradually changing shape, right? Closer to the cervical vertebra, it's going to look more like cervical vertebra. Closer to the lumbar, it's going to look more like lumbar, right? So they gradually grow in size. T1 through T12, our thoracic vertebra are more heart-shaped. The first 9, T1 through T9, vertebrae have demi-facets for the ribs to attach. And it is demi because the ribs sit in the groove between 2 vertebrae. So if you look over here, you can see how they're between the 2, right? But as we move down lower, T10 through T12, we have a full costal facet. So the rib is fully attaching to the vertebra. So you can see how it changes from between to fully attaching to. Our vertebral foramen, so the hole for the spinal cord, is going to be very circular. And thoracic vertebrae are going to have very long inferior pointing spinuses. Oh my goodness. Pointy spinous processes. They're going to be sharp and they're going to be angled downward. They're going to look a little giraffe-like. So this is giraffe-like, and then this shows you how they are very pointy, pointing downward. Okay. Then we have our lumbar vertebrae, L1 through L5. They are very large. They're kidney-shaped, bean-shaped vertebral bodies. They have more spade-shaped spinal processes. They're big and wide, stick out the back. The vertebral foramen is more triangular shaped, kind of like the cervix, or it's not cervix, the cervical vertebrae. From the side, it kind of looks like a moose if you squint. The sacrum, so S1 through S5 are fused vertebrae. The SI joints, so sacroiliac joints, on each side articulate with the pelvis. So remember, SI joints, the sacrum, articulate with the pelvis. The SI joint is actually what starts hurting during pregnancy because of the pressure and the additional weight of the baby. Sacral foramen or sacral foramina, plural. Sacral foramen are the sacral nerve tunnels. You'll see a picture soon of those, but they go from the spinal cord, from the spinal cord, the nerve endings go through these holes, or the nerves go through these holes. Sacral nerve tunnels, they allow nerves through to get to the lower body, right? Wherever they need to go. And then we have the coccyx, which in most people is 3 fused vertebra, can be up to 5, but I want you guys to know it as 3 fused vertebra for the coccyx. So, fun fact, the spinal cord actually stops at L2, so the second vertebra in the lumbar region, and it comes to a point and kind of shreds out to little nerves called the cauda equina, so horse's tail, and it goes through L3, through the sacrum, and then the nerves go wherever they need to go through those sacral nerve tunnels, through those sacral foramina. So let's look at some pictures. So 5 lumbar vertebrae. Lumbar region here. You can see they look a little different. More lumbar. And then we have 5 fused sacral vertebra. So that's the sacrum right there. And here are our foramina, our holes that let our nerve endings through. So sacral foramina there, those are the holes. And then our 3 fused coccyx right there, the tailbone. The coccyx is the tailbone. 3 to 5, but we're going to remember as 3 fused. Okay. Thoracic cage. All right, so this is the last of the axial skeleton. So ribs, sternum, intercostal element. So intercostal means between the ribs, and we're talking about anything that can be between the ribs. So nerves, blood vessels, connective tissue, muscles. That's what we mean by intercostal elements. So structure of the thoracic cage are our ribs, our sternum, and whatever's between our ribs. So intercostal elements. Sternum, 3 parts. So we have the manubrium, that is the top. Manubrium right here. We have the body right here. And we have the xiphoid process right here. Okay, so xiphoid process. The tip. So what's the significance of the xiphoid process? Why do we need to know it? Why do we need to know where it is? And why do we need to know to avoid it? Okay, so if you guys have ever taken a CPR class, you'll know that if you push too low on the sternum when administering CPR, one can actually break the xiphoid process. So what you do is you go to the bottom of the sternum, you can feel it, just push in there, and you want to go 3 to 4 finger widths up. So feel the bottom of the sternum, 3-4 finger widths up, and that's where you want to do your chest compressions so that you are not in danger of breaking the xiphoid process, because it can happen and it has happened. Where the manubrium actually hooks on the body, that is rib number 2. So rib number 2, right there, where the manubrium hooks onto the body, rib 2. That's where you listen with a stethoscope to listen to the heartbeat, right? So it should be a pretty easy method to figure out which rib you're on. That way you can start counting from there. So if you know that the second rib is where the manubrium links to the body, and that's where you put the stethoscope to listen for heart sounds, you know that that's the second rib. And you can count from there, like I said. So there are 12 pairs of ribs. We have 7 pairs of true ribs. They attach directly to the sternum. They have their own cartilage, and they wrap directly around from the front to the back and attach directly to the sternum at the front and at the back, right, to these intercostals. Not intercostals, I'm sorry. And they have their own cartilage. So cartilage attaches there, and the true ribs attach directly to the sternum. So that's 1 through 7. Then we get to 8, 9, and 10. Ribs 8, 9, and 10 are what we call false ribs. And their cartilage attaches to true rib cartilage number 7. So they are our false ribs. They don't have their own cartilage that directly attaches to the sternum. And then we have our floating ribs. So right back here, number 11, number 12. They have no cartilage. They just wrap from back and stop. They are pointy and they're floating around, not attaching to anything. So, where the cartilage attaches to the bone is common for injuries, especially in sports. Costochondritis, costo is rib, chondra is cartilage, itis is inflammation. People can get this and it can feel like they've broken their ribs, but unfortunately, just like broken ribs, there's not really anything that you can do except kind of wait out the storm there. And something else to note here, rib 1 is wide and flat, all others are slightly triangular shafts. Okay. So again, manubrium, then the body, where the manubrium and the body attach, that's our second rib. Then the xiphoid process is down here at the bottom. We have our ribs, our sternum, and our intercostal elements. Intercostal just means between the ribs. And then we have 12 pairs of ribs. 7 are true ribs that attach directly to the sternum. So they have their own cartilage. They wrap directly around from front to back, attach directly to the sternum. Ribs 8, 9, and 10 are false ribs. Their cartilage attaches to true rib number 7 cartilage. And then we have our floating ribs, number 11 and 12, with no cartilage. They just wrap around from the back and stop, and they are pointy. And then rib number 1 is wide and flat, whereas the others have kind of triangular shafts. All right, now moving on to the appendicular skeleton. And like I said, this one is going to be a pretty long lecture. So if you do need a stopping point, if you need a break, then stop here, mark it down in your notes, and then continue on because this is the second half. So appendicular skeleton are appendages. So this is the pectoral girdle that connects our upper limbs to our trunk. It is comprised of the clavicle, which is our collarbone. So that's sternum to scapula. Scapula is the shoulder blade. And we have the scapula. Like I said, shoulder blade. It is flat triangular bone. It sits between ribs 2 and 7. It's next to the spine on our upper back. So right here, these are the scapula. And then clavicles are right there. But anyways, the scapula, like I said, flat triangular bone between ribs 2 and 7. Next to the spine on our upper back. They have a glenoid fossa, so that's this spot right here. That is a shoulder socket. So, indentation in the side. That's called our glenoid fossa. The clavicle And scapula, they attach the arms to the trunk and give the shoulders their range of motion. And we're talking range of motion, we're talking AC joint, the acromioclavicular joint. And that's all I want to say there. And then we have the pelvic girdle that attaches the lower extremity that we'll talk about a little bit later. So there's our acromion, clavicle. Here's our glenoid socket, normal joint space, humeral head. So humerus is the bone of the upper arm. So in this picture, we have a bone spur right here, and we have no cartilage between the bones. So this is pain, right? Rubbing together. Here, normal joint space, glenoid socket, clavicle, humeral head, acromion. Okay, upper extremities. We have 30 bones each in the arm and the forearm and our upper extremities. So when we think arm, upper arm, we're talking humerus. So the head of the humerus is in the glenoid fossa that we were just talking about, the little indentation. So the head, it is a long bone. Remember long bones? So the head of the long bone goes into the glenoid fossa. And then the medial and lateral condyles look like a bow tie at the distal end, which we'll look at as well. Here we also have a coronoid and an olecranon fossa. So these are notches for the processes on the ulna. Okay, so coronoid is on the front, olecranon is on the back, and these are fossa, so they are notches for the processes of the ulna. Ulna is the pinky side of the forearm. Radius is the thumb side. So let's talk forearm, radius, and ulna. Remember, we're in anatomical position. Thumbs are sticking out. So radius is on the thumb side. Ulna is on the pinky side. And they are connected by what we call an interosseous membrane. So that is membrane between the bone, and it helps to keep the bones from separating. The elbow end of the ulna has that U shape with the two processes that stick up. And then the wrist end has a styloid process, which we'll look at. So the wrist end, the distal end, styloid process is actually a common fracture point in people. The radius is actually wider at the wrist end. Remember, radius is the thumb side, the bone on the thumb side. And that's also, that wider part at the wrist end is also a common place for a fracture to happen. So this is called a Colles fracture or fouche. Same thing. So fouche stands for fall on outstretched hand. So that's exactly what it sounds like. It can snap the end of the radius off at the wrist when you're falling and you catch yourself by sticking your arm out, right? So fouche fracture, fall on outstretched hand, or Colles, same thing. So let's look at these. So humerus, it's the anterior view of the left humerus, posterior view of the left humerus. So front, back. Here's the coronoid fossa, anterior view of the humerus at the right elbow joint, and this is the right humerus with the olecranon fossa on the posterior. So coronoid fossa be right here, olecranon fossa right here. Zoomed in, there's the coronoid fossa. So coronoid fossa, anterior, so front, humerus. Olecranon fossa is on the back, posterior. Humerus head goes into that glenoid fossa right there. And that's how the ulna fits in, which is the same here. Okay. So here's the radius. So remember, radius is the thumb side. Ulna is the pinky side. So this is the right radius. Anterior and posterior view. The head of the radius. And here's the ulna of the right forearm. So ulna is the pinky side. Anterior and posterior view. Olecranon process right there. Ulna. Olecranon process connects to the olecranon fossa, right? Fossa is the indentation. Process is what sticks out. And then we have the styloid process here on the ulna. Part that breaks. Common fracture point. And then our interosseous membrane between the radius and the ulna. Alrighty, so let's continue talking about upper extremities. So wrist bones are called carpals. They form the carpal tunnel, and we have two rows. Our proximal row from the thumb to the pinky is the scaphoid, lunate, triquetrum, pisiform. And then the distal row from thumb to pinky is trapezium, trapezoid, capitate, and hamate. Our mnemonic here, to remember that trapezium comes before trapezoid, is MD. So trapezium, M, trapezoid, D, M before D. MD say some lovers try positions that they can't handle. So S, scaphoid, some, lovers, lunate, triquetrum, positions, pisiform, that, trapezium, and remember MD say it, so trapezium first. They, trapezoid, can't, capitate, handle, hamate. So MD say some lovers try positions that they can't handle. And then the MD is talking about that they, so trapezium, trapezoid. So remember that. Remember that. If you are asked to name the carpal bones on the proximal row, or on the distal row, or on both, remember that mnemonic. Way to remember that carpals and metacarpals are hands and wrists. Remember that you drive a car with your carpals and your metacarpals. Don't get them confused with tarsals. Tarsals are ankles. Tarsals are near toes, okay? So tarsals, metatarsals, near toes, TTT. Carpals, metacarpals, you drive your car with your carpals, so that's what we're talking about, hand and wrist. So don't confuse those. So our hand, those are our metacarpals, so we're talking underneath the palm of the hand, and we trace those as numbers 1 through 5 from the thumb to the pinky. Number 1 is the thumb, 5 is the pinky. Fingers are called phalanges. One finger is a phalanx. Again, 1 through 5, we label them the same way. The thumb actually only has a proximal and distal phalange. The other fingers, from the pointer to the pinky finger, all have 3 phalanges in each finger. So proximal, middle, and distal. But the thumb has no middle. So we're going to look at those. Make it make sense. All right, so carpals of the right hand, anterior, posterior view. So here's our scaphoid bone, our lunate, triquetrum, and our pisiform. So that is some lovers try positions. Okay. Then we start on our distal row. So remember, MDs say this. So trapezium is first. So this is the that they can't handle part, right? MDs say that. So trapezium is first. Trapezoid, capitate, and hamate. So remember those. Metacarpals. So here are our metacarpals. 1 through 5. From thumb to pinky. So 1, 2, 3, 4, 5. Here are our phalanges. So this is what we're talking about when we're talking about proximal, middle, and distal. Proximal bones, middle bones, distal bones. The thumb does not have a middle bone, but the rest of the phalanges do. So these are our proximal bones. Got 4 middle bones, 5 distal. 1, 2, 3, 4, 5. Middle, distal. But again, the thumb does not have a middle bone. So here is a pretty good x-ray of these bones. Just another way to view it. X-ray of the hand. What's going on here, right? What's going on here? That's a break. Okay. All right, pelvic girdle. So here, pelvic girdle attaches the lower extremities. So the pelvis is made up of 2 os coxa, a sacrum, and a coccyx that make a complete circle. So this is an os coxa. This is an os coxa. This is a sacrum. That's a coccyx, right? Our 2 os coxa join at the sacrum and the pubis. So they join at the sacrum here, and then they join at the pubis here. So that's one os coxa, and that's the other one. The os coxa is made up of the ilium, the ischium, and the pubis. And the side of the os coxa is an indentation called the acetabulum. Sorry, acetabulum. So that is a socket where the 3 meet: the ilium, the ischium, and the pubis. You can see it in this picture. You can't really see it very well here, but we will see it in an upcoming slide. So the acetabulum is a socket where the 3 meet, and that's where the femur attaches. Let's see. Asis and PSIS. So that is the anterior superior iliac spine. It's right here. And the posterior superior iliac spine. So those are the ends of the iliac crest. On your lower back, you see 2 dimples where the pelvis is closest to the skin, and that's the posterior superior iliac spine. So that is the top of the iliac spine on your back, essentially. Where those 2 dimples are is the top of that posterior superior iliac spine. So top of the pelvis on the back side. And then the anterior superior iliac spine, the top of the pelvis on the front side, is the, so we're at the back. So you just felt your iliac crest on the lower end where the 2 dimples are. So you found your posterior superior iliac spine. And if you follow that bone all the way to the front, in really thin people, you can actually see the pelvis or hip bone sticking out at the front near the waist. That's the anterior superior iliac spine. So that's the front side. So both ends of the top of the pelvis, anterior and posterior, basically is what that is. Both ends of the top of the pelvis. The sacroiliac joint, that's where the ilium attaches to the sacrum. So that's right here. The ischial tuberosities. So that's where we sit, right? Those are our sit bones. The ischium is the round part with the hole in the center. Right here, that's the ischium. Right here's the ischium. And the tuberosity is the bottom bumpy part. Hamstrings also attached there, and the sacrotuberous ligament exists there. That's what keeps your pelvis together, keeps it from falling apart. Pubic symphysis, that is right here where the two pubic bones attach. And then the pubic arch is actually the angle made there. So angle formed from one ischial tuberosity to the pubic bones to the other ischial tuberosity. So that's just a really complicated way to say that is this angle right here. That's the pubic arch. Okay. In females, the pubic arch is going to be wider. So that is for delivery of baby purposes. In males, it's going to be a lot more narrow. In females, the acetabula is going to be on the side, whereas the acetabula in males is going to be more towards the bottom. Let's see. What else? Sacrum coccyx is straighter. Male sacrum coccyx pointed anteriorly. The pelvic inlet in female is going to be more oval shaped, and then in males the pelvic inlet is going to be a lot more heart shaped, which we do have pictures of that as well. So here's the ilium right there, the ischium, and the pubis, and then that's the pubis symphysis. That's the pubic arch right there. All right, female pelvis, you can see how it's more oval-like. Male pelvis, you can see how it's more heart-shaped. Okay, sacrum right there, pubis right there. Acetabula are those sockets. Ischium's right there, ilium's right there. Acetabula, that socket, that's where the femur attaches, right there. Femoral head, femoral neck, and the femur. Here's our pelvic bone. Oh, that's cool. This is a child view where you can see the growth plate. Epiphyseal plate. And then here's some more hip. Femoral head attaches to the acetabulum. Okay, lower extremities. More on lower extremities. So our thigh, that's our femur bone. That is the largest, longest, and strongest bone in the body. That angle that we were talking about, where the head of the femur attaches to the acetabulum and the pelvis, that's called acute angle. So that's right here. In females, it's going to be a lot greater because the acetabula are going to be more on the sides of the pelvis, right? So the femur is going to go out and down. Patella, that's our kneecap. That's the large bone in the quadriceps tendon. It's a sesamoid bone. It forms in the tendon to keep the tendons from rubbing on other bones. So sesamoid bones allow for pivoting, and it's obviously really important for the knee, right? It's got to pivot. We have a patellofemoral joint, and that's exactly what it sounds like. It's a joint that forms between the patella and the femur. The lower part of the lower extremity, so the leg, the tibia and fibula. So fibula is going to be the skinny one. So remember, little fib, it's the little one. Tibia is going to be the bigger bone there. The leg is made up of these two. So the fibula is not part of the knee joint. It actually makes a lateral malleolus on distal end. So that's the bone that's sticking out on the outside of your ankle. It is actually part of the fibula, and not the ankle. It's called the lateral malleolus. The inside bump is called the medial malleolus, and that's part of the tibia. So what is commonly referred to as ankle bones that are sticking out is super wrong. So don't get confused what we talk about in vernacular, just day-to-day speak, with actually what's going on anatomically, okay? So the lateral malleolus is the outside ankle bone in vernacular, but it's not an ankle bone. It's part of the fibula. And then the inside is part of the tibia, and it's called the medial malleolus. So now let's actually talk about ankles. So ankle bones are called tarsals. They're near the toes. Remember, they're not carpals. Carpals drive the car, your hand. So those are going to be your hands, wrists, right? Tarsals, metatarsals, those are going to be your ankle and footsies, right? Ankle and foot bones. So ankle, tarsals near the toes. So ankle bones, we have the talus. That's the bottom of the tibia and fibula. We have the calcaneus bone, that's the heel bone. We have a navicular bone, that's boat-shaped. We have 3 cuneiform bones on the top of the foot, and then we have a cuboid bone on the top of the foot, which we'll look at. In our feet, we have metatarsals, number 1 through number 5, starting medial to lateral, so big toe side to pinky toe side. Same with toes, phalanges, number 1 through number 5 from the great toe. Great toe is actually called the hallux, fun fact. And then we have 3 arches. So we have 2 longitudinal arches, they're medial lateral, and we have a transverse arch. Okay, so femur, so right femur, biggest, longest, strongest bone of the body. Head of the femur goes into that. Acetabulum, we have the neck of the femur there. What's called the greater and lesser trochanters. Linea aspera and gluteal tuberosity. Shaft of the femur. Medial condyle, lateral condyle. Patellar surface. And then we have the patella, the knee bone. This is the tibia. Here's the tibial shaft. What we call the anterior crest of the tibia. And we have medial malleolus. So that's the inside bone that sticks out. And then the fibula, skinny little fib, head of the fibula, and the lateral malleolus. So that's what sticks. That's the bone that sticks outside. Shaft. And then we have the interosseous membrane here as well. Okay, so tarsal bones of the ankle. Right ankle specifically. We have the talus. Calcaneus, the heel bone. So remember, talus is right off the tibia and fibula. Calcaneus is the heel bone. We have the cuboid and the navicular, which is boat-shaped. The 3 cuneiform, so lateral, intermediate, medial. Know that there are 3 cuneiform tarsals. Then we have our metatarsals. 1, 2, 3, 4, and 5. Phalanges of the right foot. We have our proximal phalanges. Sorry, one moment. I had to get a drink of water. We have our middle phalanges. No middle phalanx in the hallux. Our big toe. So same as the thumb, right? And then our 5 distal phalanges. Here's another image of the knee. Here's the patella, femur, tibia, fibula. And then here's another image of everything we just talked about if you need another way to study. Okay. And lastly, to tie all this up. So in development, we have what are called fontanelles. Those are the soft spots on infant skulls. It's important because it allows for compression as the head goes through the birth canal, and it allows bones to grow gradually. We already talked about the kyphotic curve, so it's a complete C shape at birth, so it's all kyphotic. We don't start alternating lordotic and kyphotic until the baby starts getting older and learns how to hold their head up to stand, to crawl. That's when we start alternating between lordotic and kyphotic curves. Some problems that can arise during development is a cleft palate or a hair lip. So the left and right side never fuse together before birth. Sometimes the cleft palate can be a straight opening to the nose. Surgeries tend to try and repair these different situations. We already talked about scoliosis with the lateral curve. There is also something called kyphoscoliosis. So that is scoliosis plus a humpback at the same time. Hip dysplasia. So that's shallow, unstable hip sockets, and that can cause the hips to dislocate pretty easily. A dowager's hump is a very, very, very pronounced curve in the back where it looks like somebody's looking down at the ground. That's how pronounced. Ossified costal cartilage. This happens when the rib cartilage starts turning to bone, so then there's no flexion, right, of the ribs to allow for breathing. So that's really, really bad one. And then we also have something called facial bone resorption, where the jawbone disintegrates essentially. And that wraps it up on this hour and 22-minute lecture over the skeletal system. And we'll go over these as well with our skeletal articulations and our disarticulated bones. Thank you for tuning in.